This is a technical presentation on arthroscopic double pulley remplissage as part of the virtual fellowship. The remplissage procedure, in addition to a Bankart stabilization, can yield an excellent anatomical and functional result. Below and Company out of France published a study showing that filling in this Hill-Sachs defect with the posterior infraspace rotator cuff can stabilize the shoulder effectively. Here's a figure from their article. In figure A, you see the Hill-Sachs defect being created by the anterior glenoid. In B, you see that Hill-Sachs defect engaging despite a Bankart repair being done. In C, a remplissage is added, filling the posterior Hill-Sachs defect with rotator cuff, preventing instability of the shoulder. Arthroscopic photos from their article show in figure A the Hill-Sachs defect, two anchors being placed into the defect, a sharp passer in section C of this diagram used to grasp one suture from each anchor, pulling it through the cuff and then tying it in the subacromial space and reducing the rotator cuff down as in figure D. I've drawn out a diagram showing the traditional remplissage technique where one anchor is placed into the Hill-Sachs defect. A sharp passer is then used to penetrate the rotator cuff to pull one limb of the suture through the rotator cuff, tying it down. An alternative is to pull both limbs through the rotator cuff, tying it down, dimpling the rotator cuff down into the Hill-Sachs defect. Traditional remplissage technique involves inserting an anchor into the Hill-Sachs defect percutaneously or through an accessory cannula viewing from the posterior portal, then using a sharp bird beak passer to penetrate the rotator cuff and retrieve one or both sutures from the anchor. Next, proceeding with the Bankart stabilization, clearing the subacromial space, and then tying a sliding locking knot with the sutures, thus reducing the cuff down to the Hill-Sachs defect. Disadvantages with the traditional remplissage technique are that it is technically challenging due to the need to repeatedly penetrate the rotator cuff. It's difficult to achieve a large separation of two sutures in the rotator cuff. When you do achieve large separation of both sutures in one anchor, it creates a bunching effect of the cuff. A single anchor is not effective for large, broad Hill-Sachs defects, and when you use two anchors, you produce multiple reduction points into the Hill-Sachs defect rather than one sheet of reduced tissue. I've created here a schematic of the double pulley technique for arthroscopic remplissage. Instead of using one anchor and then a bird beak to pass sutures, here you use two anchors, place them in the broad Hill-Sachs defect, and you essentially tie them to each other in the subacromial space, creating a suture bridge to dunk down the cuff into the Hill-Sachs defect. In order to achieve this, you take one end of a suture from the first anchor and tie it to another end of a suture from the second anchor. You've thus created a hard stop and one continuous suture that goes through both anchor eyelets and back into the subacromial space. You then slide a locking knot with several half hitches and cinch the second set of sutures down to reduce the cuff into the Hill-Sachs defect. The actual steps for the double pulley technique are to first insert two anchors into the Hill-Sachs defect percutaneously or through an accessory cannula viewing from the posterior portal. Next, proceeding with the Bankart stabilization, then clearing the subacromial space, tying one end of the suture from anchor 1 to another end of the suture from anchor 2. Then, tie a sliding locking knot for the remaining ends of the suture from anchor 1 to anchor 2. This effectively uses the eyelets from each anchor as a pulley from which a mattress suture sinks down on top of the cuff and reduces it into the Hill-Sachs defect.